so excited today to have a physical therapist who also has rheumatoid arthritis. This is a double whammy. We have Dr. Kimberly Steinbarger, and she is a physical therapist and assistant professor at Husson University in Bangor, Maine. So I'm talking to her from Washington State, separate, a totally opposite side of the country. So she's had rheumatoid arthritis for 32 years, and she also runs a pro bono clinic specializing in rheumatic disease in her research and practice. So welcome. Thanks so much for being here.
Thank you for having me.
Yay. So I just gave away my first question, but so why did you, I'll just say, why did you become a physical therapist, and how did you end up specializing in helping people with inflammatory arthritis?
Well, when I became a physical therapist, I did not have RA yet. So I went through college. I decided to become a PT because I wanted to be in the healthcare field, and I didn't want to go to school forever.
Yeah.
So back then
Narrows it down.
It was a 4-year degree, and I really enjoyed the topic. And after I graduated in 89, I was diagnosed 2 years later with RA in 91. And I kind of knew what it was because of my schooling before I was diagnosed. But, back then the diagnosis was kind of was a very long process. And so that kind of started my interest, but I didn't really pick it up until I was in my 40s. And I started doing more research and getting more involved in the community, the arthritis community, as I aged.
Mm-hmm. Well, and to rewind a second to your diagnosis time, were you concerned about how having RA would affect your career as a PT?
Oh, I didn't tell anybody.
Oh, but I mean, just
For
symptom-wise,
years.
were you
Decades.
concerned that you would be able to do the job?
Yeah, or that there would be a bias.
Yeah.
Physical therapists, we're the healthy, we're in good shape, we move people around, and there was a dichotomy there with my diagnosis, and so I didn't tell anybody for the
Was it,
long time.
oh my gosh. And was it hard to do your job? Like, what kind of setting were you working in?
I was working in a hospital.
Okay.
So luckily we rotated through the different levels. I was actually in Honolulu, Hawaii at the time when I was diagnosed.
Oh my gosh.
I had
Wow.
nothing better to do after school, right? To move to Hawaii.
Yeah.
And so I luckily I rotated through. So some of the floors were more physically demanding than others. And I always had very good rehab aides, physical therapy assistants, to help me if I needed some help.
Yeah, yeah. And that's a huge concern for so many people who are recently diagnosed. Can I still, do my career? And so to me, it's like heartening to hear that you were able to kind of compensate for the pain or fatigue.
Yes. And I was so young. I was 24
Yeah.
when I was diagnosed. So it took me quite a few years to be able to kind of advocate for myself and say, okay, you know what? I'm really good at this job, and here's what I need in order to do it well.
Well, and
Yeah.
just to deviate a little bit, so we have a little plan here I'm already deviating from our plan of questions, but just out of curiosity, I know you were diagnosed right before like the biologics were coming out, right?
Yeah.
So medication wise, how was if you don't mind sharing, like
I
what?
don't mind. I took gold.
Wow. Okay.
Yeah, that's how old I am. Yeah, I took gold for several years. I took some of the NSAIDs, the Trilosate, Zolpidem, all those older ones. I took those for a lot of years, until I finally started methotrexate maybe 10 years in.
Wow.
And yeah, so I was lucky because back then I had doctors that treated it aggressively right away.
Mm-hmm.
They didn't start me with the aspirin and the Tylenol, and the kind of really, over the counter type treatments. They were very aggressive right away. And I was really, very much for that at the time. And at the time, being as young as I was, I didn't realize what a wonderful thing that was.
100%.
That way.
Yeah, yeah. Well, and I'm just curious if 10 years in, had you started having any like deformities or anything like that? Or were you more well managed when you started the biologic?
Oh, no, I would every day when I get in the shower, I would stretch my hands out because that's where it started for me was my hands.
Me too.
And trying to wear good shoes for my feet. Luckily for me, my big joints weren't affected unless the inflammation got really out of control. I have
Mhm.
like a sequence. If it
Yeah,
gets
yeah.
out of control, and so it was mostly my hands, and I think my education really helped me because I knew how to keep my fingers, from deforming, and
Mhm.
how to keep track of what was getting tight and how to stretch it out. And so I knew that, and I was very aggressive with that at the beginning.
Well, and that's so, and I know both of us are so motivated to help other patients, living with inflammatory arthritis. And it's such a shame that all newly diagnosed patients aren't given, access to physical therapists,
Oh yeah.
occupational therapists to help them. There are so many things you can do, like you mentioned, but they're very specific. The kinematics, the kinesiology of the human hand is so incredibly complex. You can't just
Mhm.
intuitively figure it. I mean, it's better than nothing to just kind of intuitively like, I'm going to move my fingers the way that they move
Yeah.
and just do something. But still, sorry, I'm getting off on the soapbox already. But yeah, speaking of, being a physical therapist, and I think a lot of people would be curious, like, what is your, we always talk in occupational therapy about our elevator speeches. For
Mhm.
you, like, do you have an elevator speech if people say, what does a physical therapist do to help someone with rheumatoid arthritis?
I do actually. I
All
can
right.
I can I can walk through your life with you, find out what are the things you've given up, and can we get those back?
Mhm.
What goals do you have for movement, for life, for your roles that you play every day, whether it's work, school, home, mom, dad, whatever your life role is. What are some of the tasks you need to be able to do to fill that out? I can help you with that. And it's not just about going to the gym and exercising. It's about how to manage your life.
Wow, that's so congruent with occupational therapy too. This like why we're like the dream team. But
Yeah.
yeah, it's so true. It's about using the modality of physical activity to get
Mhm.
at whatever the underlying deficits, quote unquote, or challenges are that are preventing you from performing your daily activities. I don't know if that's if I'm putting words in your mouth, but that's another way of putting
No,
it.
yeah, that's fine. It's we give up a lot of things
Yeah.
when we are in pain. And what's the first thing to go? It's usually the fun stuff, the leisure activity, the things we like to do, right? Or, those roles that maybe we don't go to church and that's important to us because of mobility issues or access issues. Those are things that a PT can help you with. Those are important. And trying to get some of that back. And one of the first things I ask my patients is, what do you enjoy that you're not doing anymore? And let's see if we can figure out a way to bring it back into your life. It's
Yeah.
not always about walking, running, lifting weights.
Yeah.
It's about everything else, that the other 99% of your life.
Hmm. Oh, I mean, I so resonate with that. And yeah, it's about doing, I just wrote down doing what you love. I mean, that's like such a I mean, who wouldn't want to see somebody who can help them? But I'm saying like, I feel like I'm like on an advertisement right now. Like you should do PT. But that is, we're trying it through this podcast episode, spoiler alert, going to try to help people bust some of the myths they might have about physical therapy. Like I was telling you before we started recording, it's like I kind of had this impression too that physical therapists are kind of quote unquote gym bros, like people who just care about like pumping that iron and like, getting huge muscles. And and unfortunately I have had, seen patients who've told me, oh my gosh, I had a bad experience with a physical therapist, and that's just about, unfortunately, with whether it's counseling, whether it's rheumatology, whether it's a
Yeah.
pediatrician, there are some good providers and not so great providers out there. So one thing I would say is if you had a one bad experience, try to seek out somebody in the physical therapy world who really has experience with an autoimmune inflammatory type of arthritis
Mhm.
as distinct from osteoarthritis. What would be something else you would want patients to, or something else you wish patients would know about physical therapy, or like any myths that you might want to bust?
Well, exercise is kind of our
Yes.
big thing. We're movement specialists, but there's a lot of things that relate to movement that aren't exercise. We can talk in general terms about things like diet. I can talk to you about your fatigue and how to manage your fatigue. We can talk about how to modify activities if they're not seeing OT for that. I can talk about, how to modify some activities to make it make their workflow better. How
Yeah.
can we set up your workstation? How can we schedule your day to kind of balance activity with rest? So it's not just about exercise, it's about all of the other things that you need for good movement. You need
Yeah.
nutrition, you need energy, there's a lot
Yes.
of other things there.
I think that's really a good, I'm working on like pausing and digesting the things people are saying because my brain works at like, there's a saying about people with ADHD that they have like a Ferrari mind with bicycle brakes. I don't know if you've ever heard that saying, but I'm working on developing some Ferrari brakes because that's a really beautiful, important statement that it is about analyzing your movement, the way that you move through this earth and through your physical environment and your energetic environment, not in like a woo-woo sense, but like in a fatigue sense, like the
And a little bit
environment.
of woo-woo too,
A
but
little, why not? Yeah. Like what if that's important to you? Yes, let's
Yep.
go to the woo-woo, and saying like, if I can pick up my water bottle with two hands, that disperses the weight of this water bottle across two hands. And if I put my fingers in a certain way, it's going to put less stress on them than if I pick it up like this. Sorry, this is I should know after 100 episodes, this is an auditory medium. If you're watching it on YouTube, you can see the video. But if you pick it up with one hand, it's going to take, all those little micro interactions that you have throughout your day. You can have a physical therapist or occupational therapist. That is one area where we definitely overlap that we can analyze and kind of use our detective brains to figure out how could you be more efficient or how could you move through the world with more ease and joy,
Yeah.
And
We
you
can talk
mentioned
about sleep.
sleep. Yes.
Yeah.
Sleep, the forgotten lifestyle fact.
Yes. Yeah. How do you sleep? Is there a position, for me, I had a hard time sleeping. I would wake up
Yeah.
all the time until I found the right bed. And once I found the right bed, I slept through the night for the first time in probably 30 years. And I was like, wow, is that what that's like?
Was it, I'm now everyone's gonna want to know, was it like a more firm mattress or was it a less firm? Like what was for you? I know we're all different, but just
Yeah, no, it was something that I could adjust. I could adjust the foot.
mm,
So, which was nice. And I could also adjust the head and the foot.
yeah.
Which was nice that I could change it because our disease is very cyclic. It comes and goes and ebbs and flows, and so what one position might not work one night works great the next. And with a more adjustable sleeping service, I found that worked very well for me to get a better night's sleep.
That's so crucial. It's so funny that you say that because in one of the Room to Thrive support groups that I facilitated, there was a physical therapist who also has RA. And I asked her, in all your experience with RA and your own life experience, like I said, I'm on this ever long quest to find like the perfect set of pillows. And
Oh,
yeah, such as I hurt my neck in a car accident in 2016. And so there's like, there's acute illness, acute injury turning into chronic pain from that
mhm.
injury layered on top of the inflammatory, arthritis. And so she was like, honestly, this is going to sound so simple. She's like, but after so many years and trying things herself, she's like, my best set of tools is like a set of whatever pillows that you have come up with or set of pillows that's like a variety that works for you. But she's like, but also a set of small to medium hand towels that you can roll up
Roll
and
them up.
put
Yeah.
exactly into the spaces. And I was like, it's so simple. It just might work.
Yeah. And you can stuff it in the pillowcase along the long edge of the pillow.
Oh,
So
that's
it
next
stays in
level.
place. Yeah, it's very simple.
That's so
I have
great.
so many pillows in my house. My kids would laugh me
Oh,
talking about it because I would try them and discard them, and so they go on
yep.
another bed in the house.
Yeah.
I have
Oh,
more pillows than a woman needs.
we need like a pillow collector support group. Yeah. But, so you've mentioned so far, just in our brief conversation, you've mentioned, physical activity, sleep, diet and nutrition. Coincidentally or not so coincidentally, these are the three main things, that were looked at at the 2022 American College of Rheumatology Guideline for Exercise, Rehabilitation, Diet, and Additional Integrative Interventions for Rheumatoid Arthritis. I tried to say it in one breath, but I couldn't.
That was pretty good.
Yeah. And this has become like, for me, it's like, I don't want to say Bible because that's a totally different thing, but it's a really important synthesization document that kind of that I would love to hear from your standpoint as somebody who helped create these guidelines. Well, okay, just skipping to the end really quick, there is a chart that is the result of this many years long research-based process that has things in color codes that are to do with exercise, rehabilitation, diet, and additional things. And we'll talk about those. And so it's a starting point because lifestyle is so overwhelming for RA that this is saying, look, not just cherry picking certain articles that go with what I already want to do, but what is the breadth of the research saying is going to give you the most bang for your buck as a starting point. And so, sorry, I just like rambled about it, but tell me, I would love to hear a little bit more about, how do documents like this from the American College of Rheumatology, how do they come about? What was involved in creating this?
So this was my first time working on a guideline. So this was my first one. And I was naive as to how much work, it's a good 2-year process. And it takes an entire team of people to take thousands, literally, of articles and condense them down into the ones that make it at the end, so you end up condensing them down to 100 or so or less. And it's a huge, long process to condense them. You read the abstracts, then you read the articles of the promising ones, and each time you're knocking articles out that don't make the cut. And so then you're left with a pool of articles, a year later, that you can now try to synthesize into recommendations. What recommendations from what we read can we make with either a strong recommendation, a conditional recommendation, or a weak recommendation, or no recommendation? And that's what the guideline does. And that chart is really a great place because the guideline is pretty long, but the summary chart is nice because it color codes it, like you said. And the only strong recommendation was exercise. That was the only strong recommendation out of that whole 2-year process.
And by the way, that included looking at, so you have 19 people, all of who have professional degrees and are experts in their fields, PhD, I'm looking at the people's names, DPT, Doctor of Physical Therapy, doctors, regular medical doctors, occupational therapists, social worker, master of public health, PhD, and they're looking objectively at all this data. And so consistent engagement exercise was more strongly recommended than comprehensive physical therapy or comprehensive occupational therapy. So we're like, wow, we went to our degrees. And actually, if we just got people to exercise, no, it doesn't mean that it's not effective, right? So it's just, I think it's important to look at this objectively and say like, wow, that if you're a patient and you're like, why does my doctor keep harping on exercise? Like, or that seems so unrealistic, or it just seems like they're not listening to me because I'm in pain and you can't exercise if you're in pain. It's like, it's because the wealth of the evidence is stronger for exercise or engagement and consistent engagement in physical activity than it is for diet, than it is. It's just objectively true.
Exercise is the best medicine that nobody uses.
Yeah. Well, some people do.
It's hard, but it's hard, right? Asking people, if I'm asking somebody to exercise and eat right, those are two things we don't want to do. It's hard. And I understand that it's hard. So that's why it's really important to start with baby steps so that it's not overwhelming and it doesn't have to be as hard as it sounds.
You've totally anticipated my next question. And I think it is, so if someone knows this and they're like, I'm just going to look at this chart, which is on page 2 of the guideline summary. I'm going to link, there is 3 separate documents that I think are really important. One is like the 13-page peer-reviewed journal article that like summarizes all of this for like professionals. And then there's the 2-page summary. And then there's the 564 page Appendix 3 Supplementary Appendix Evidence Report. And I know that a lot of people in the healthcare field knock, social media, or think patients are just getting misinformed on there. Well, I've had a lot, since I've been talking about these guidelines, a lot of people have asked me, where do I learn more? Where can I see the original articles, summaries of these articles that form the basis of this report? And I'm like, look, you can go look to the section on diet or on supplements, why are supplements not recommended? You can look on this document on page whatever. It's one of the pages between 1 and 564. There's you can look and see where it's going to be. And that these are listed as, okay, we're going to get to how people can get started, but I wanted to say on this Appendix 3, because I'm getting real nerdy here, but it's really interesting, because it says, so the way that things are framed in these guidelines is, for example, on dietary interventions, question 1, should patients with RA use a formally defined diet? Question 2, should patients with RA use a commercially available dietary supplement? Number 3, should patients with RA who are overweight or obese receive a weight loss intervention? You're going through each of these questions, and then is it right to say that you'd be synthesizing the research within each of those?
The questions is where we start. They're called a VICO question, and that's where we start the whole process, is coming up with the questions. Here are the questions we want to answer with the research, and then we can target our search.
Yeah. And I love this because it's so practically relatable to what patients, these are literally the things people ask me and the support groups, and where I created my own self-management program, which coincidentally, standardized self-management programs are conditionally recommended. So that's good. Again, strong recommendation, there's only one, and that's consistent engagement exercise. There's a lot of ones that are conditionally recommended, which, can you remind us what's the difference between a strong recommendation and a conditional recommendation?
So strong is that the evidence is strong to support the use of this for most people with the diagnosis. Conditional is that the evidence isn't as strong, it's moderate, but so for certain conditions, for certain people, it works really, really well. Like, say, take physical therapy, for example. Not everyone benefits from physical therapy. It's conditional. If you see the right physical therapist at the right time with the right treatment, you get a really good benefit. But they can't say, is it always going to help? No, we couldn't find the evidence to say, yes, it always does. But exercise was pretty strong across the board.
And
looking.
So in a way, it would almost be, conditional recommendations are almost, in my head, there's some caveats, maybe, it'll probably help you, but it might not help you as much if XYZ. Maybe you have a bunch of comorbidities, or you have, so a lot of stuff is in there, specifically aquatic exercise, hand therapy exercises, splinting, orthosis, compression, bracing, and or taping, which is, again, it's kind of interesting as an occupational therapist nerding out about this, because you're or joint protection, how on earth is joint protection? What could it not be helpful with? Potentially, maybe just if you protect your joints too much and you have immobility, right?
And a lot of the problem was not so much that joint protection was bad in an instance, but just that the studies weren't strong enough. Maybe they had some bias in them. Maybe they didn't have a large population. Maybe they weren't well controlled. So it's not necessarily, if it's conditional, it was bad for people, but there's not enough evidence, strong, good, non-biased evidence to say, yes, this helps.
I remember seeing that for compression gloves. I really dug into the research for that, and I was surprised given the amount of kind of positive feedback I've seen. Now this is not a randomized control trial, right? But just in my own personal experience, I'm like, wow, this really seemed to help people. But yeah, the evidence is just not objectively as strong. It's not, there's nothing wrong with it. There's nothing evidence that it's ineffective, but they're not, the evidence for it isn't as strong. So actually, I will stay on this train of thought before we go into getting started with movement and exercise, because I think this is important to understand the difference. If you're looking at this chart, page 2 of the Integrative RA Treatment Guideline Summary, which is just the 2-page summary. This is the chart that has different greens and reds. None of the things were strongly recommended against, but 4 of the things were conditionally recommended against. So what makes something now interesting? These 4, I'm going to say them out loud because I think these are interesting, because these are some of the things people ask me the most about and that I see the most misinformation online about, especially diet. So any formally defined diet other than Mediterranean style is conditionally recommended against. Any dietary supplements are conditionally recommended against. That does not mean for you as an individual that the keto diet or the paleo diet or vegan or specific other, autoimmune protocol, there's evidence that that's going to be harmful to you specifically. But at the population level, looking at large numbers of people, right, that there's something about these that's not just not that helpful, it's what makes it conditionally recommended against.
I think a lot of the problem with, say, for example, diet, when you take a group of people and you try to do a study on how they eat, trying to get everybody to eat the same way for a certain number of weeks is impossible unless you have them in a very artificial type of an environment, or where you're actually providing the food for them, which again, it makes it very well controlled, but is it realistic? And we look at both of those things. And so, it can be really hard to recommend something when the studies are kind of all over the place. If you control it really, really well, it's not practical and it's not realistic. So you have to finding that balance is really hard. So there is the Mediterranean diet was one of the ones that it just had more evidence, more studies were done on the Mediterranean diet than anything else. So that's the one that got the conditional recommendation. And then you couldn't make any recommendations about anything else.
Yeah, I think it's worded so you just summarized it really well. And I think that the wording is really powerful or really helpful in the 13-page journal article itself. I'm sitting here looking at page 8 here, and it says, we conditionally recommend against adherence to the formally defined diet other than Mediterranean based on very low to moderate certainty of evidence demonstrating no consistent clinically meaningful benefit from following other formally designed diet strategies on physical function, pain, or disease activity specific to RA. In addition to the level of certainty of evidence, this recommendation is conditional because of the burden and costs that accompany adhering to a formally defined diet, and patient preferences are expected to differ. I think taking into account, that's what's so crucial. What I have to tell people is, look, if there's someone out there trying to peddle you a way to manage your arthritis fatigue that is really low cost and low time consuming, that's like, you need to turn around and bounce on one foot for 3 seconds every day, once a day. You're like, sure, like, what do I have to lose by doing that? Not a lot. But for some of the really strict diets that you are losing, potentially your cost benefit analysis is, I'm spending these precious hours of my only life here on earth obsessing over food, spending considerable money on something that may not actually end up working. I'm not saying against it if that's what you value in life. And this is where context is so important. If you're super rich and you want to throw every single possible tool in your toolbox, that is totally makes sense in your life. But if you're like, look, I only have so many hours in the day, so much money, where do I want to put my energy? That's where the guidelines can be helpful. Or would you agree with that? Sorry.
Oh, absolutely. Because, and especially when you think about someone with RA or any rheumatic disease, your energy is limited. So you need to be very selective about where you're putting that energy. I tell my students here, I say, if you're going to, prescribe an exercise, for example, it better be a damn good exercise, because if they're going to expend the energy to do it, it's got to be worth the time.
Yeah. And I think the supplement part is important to dig into the details for people who are interested in reading more, because it talks about the idea of having it's not to say that the vitamin contained in the supplement is necessarily bad or ineffective, but their voting panel supported a food first approach, but recognized that the dietary supplements may serve a role for bone, like vitamin D, and cardiovascular health, like fish oil. But then the recommendations refer to those produced by the U.S. Department of Agriculture and Health and Human Services and the Heart Association. So it was just interesting that they kind of had those caveats in there for the supplements, because that's something a lot of people ask: what natural quote unquote supplements can I
Right.
do?
And I think part of the conclusion there was that the supplement recommendations aren't right now. We
Mm,
don't have any evidence to do anything different for someone with rheumatic disease versus somebody without. I mean, the
mm,
USDA and their recommendations are fine for most people, and including people with rheumatic disease. There wasn't a differentiation that could be found, and there's so
mm.
much conflicting research out there, as you know, on supplements and what to take and what not to take, and does this work and does that work? And so there really wasn't a clear conclusion other than what the guidelines already are established for the adult population.
Yeah. Yeah. That's really important to know that they're talking about supplements specific for RA. Yeah.
Mhm.
And I think the last one before we go on to diving deeper into exercise would just be, I think actually probably the best place I should have started with looking at the recommended against, conditionally recommended against, is chiropractic, because to me as a patient looking at cost benefit, the most important thing to me to start with is, could this harm me? Could this harm me in a way that would last a long time?
Mhm.
And it's very possible that, I'll just say from the guidelines themselves, in the absence of evidence, we conditionally recommend against chiropractic therapy via chiropractic spinal adjustment directly for the management of RA, because of the potential cervical spine complications that can occur. So that's, to me, that was pretty important to take into account, that you could actually get hurt doing this. I mean, supplements, there's certainly supplements people have been hospitalized for. Dr. Karawada, if you remember that episode, she's an allergist immunologist who has Sjogren's and was hospitalized due to liver side effect of a supplement she had been taking to try to naturally manage her Sjogren's. So there are harms that can come from supplements, or for any activity, exercise if you do overdo it and hurt yourself. But chiropractic is like directly, potentially can be harmful. Is
Right.
that how?
Yeah, and a lot of that is, even for PT, we do some manipulations if you're properly trained,
Mhm.
and that's like the number one contraindication is somebody that has RA, particularly if it affects their neck and you don't touch it.
Yeah.
Uh, so that is actually a really big caveat
Yeah.
to
Yeah. And so if you don't know, having rheumatoid arthritis um, can lead to, I don't know how to pronounce it, cervical instability of
yes.
the atlas and the axis, like C1
Mhm.
and C2, which are like the vertebrae right below your skull, where like
Yeah,
your
yeah, your
brainstem is.
brainstem is there.
Yeah. It's kind of important for like breathing and life. And unfortunately, you might have heard of people. Again, I'm not saying all chiropractors are going to harm someone, but it's by any means, majority of chiropractors obviously are doing,
Mhm.
something that people perceive as helpful. Otherwise, it wouldn't continue to exist as a field. But you know, if something someone's about to do, there's a risk benefit analysis has to occur. If the potential risk is very, very high, the potential benefit needs to be very high. And the potential benefit is very, very inconclusive of chiropractic, lack of, uh, there's a lack of benefit from chiropractic therapy for RA. And indicated that this approach carries a perceived burden and cost. I'm reading from the thing. And it's important to mention that, because this part of the guideline actually talks about the voting panel and the patient panel. So I mentioned earlier, because I was being kind of an academic snob, saying that, I'm a little bit of a snob, not snob, but to me, the degrees mean something. I'm not going to be, it means something that people have devoted their life to these things, but also it means something that patients are the experts in their own care, and patients have
Mhm.
lived experience that contributes to these guidelines too. So there was the voting panel of the experts, and then there's the patient panel,
Yeah.
and they were able to vote on these as well. Is that right?
Yep.
Yeah. It's really, I mean, yeah, I think this is, again, I've been like proselytizing, if that's the right word for this, telling people to check out this guideline, because you can, yeah, it's like doing a lot of people want to do their own research, and it's important to do your own research on different interventions, but it's amazing that someone's already kind of like amalgamated the important, like many of the important research
Yes,
things for
yes.
you.
I
So
mean, just
yeah,
the number of man-hours of hundreds of people
yes.
put this together.
Yeah, it's more efficient to start there than just try to do it all on your own, in other
Mhm.
words. But okay, so we earlier, 10 minutes ago or whenever, we were talking about not knowing. A lot of people tell me, where do I start? I'm overwhelmed, or I tried one form of exercise and I felt worse, and now I'm scared to try something else. What do you recommend as a starting place for, and I know I use the word exercise, but we maybe for increasing physical activity would be
So, so yeah, and I try to rephrase it as physical activity because, exercise, what do you think of? We think, oh my gosh, I've got to get changed. I've got to go to the gym. I've got to work out. And then I've got to take a shower. And then I've got to get changed again and go back. It's a long process. And for someone with limited energy,
Yeah.
that is exhausting. It's exhausting just to think about it, right? But if you try to frame it more in terms of physical activity, do you like to garden? That's physical activity. Are you doing housework? That's physical activity. The WHO, actually, the World Health Organization, has a statistic that I love. And it's, if you can do 5 more minutes of physical activity than what you did yesterday, it improves your health.
I love that. Yeah.
I love that stat.
Yeah.
And I tell patients that too. You don't have to start with hour Zumba class 3 times a week. Maybe you tend to only walk around your house. Maybe you walk to the mailbox. If you only think you can walk to the mailbox, maybe you walk a little ways down the street. Try to go a little bit further. You don't have to, tackle the world right out of the gate. It's baby steps. It's just a little bit more walking. Do something you enjoy. I really am a proponent of doing something you enjoy. What's something that you dropped out of your life that because of the pain and because of the fatigue that maybe you want to try to do? And we can look at that. I had a woman that she quilted, and I didn't realize her quilting machine took up her whole garage. She walked around that quilting machine. I don't know how many times we put a pedometer on her, and she was getting all kinds of physical activity. Never realized. I said, well, there's your start right there, and you're doing something you enjoy. So it doesn't seem like exercise, but it is.
Yeah. I once heard someone use the phrase incidental exercise, which I really like. It's like,
I like that.
yeah, when I used to go swing dancing, I'd be like, well, yeah, I understand there's a benefit for me of physical activity, but the reason I went dancing was to see my friends and have fun and, and listen to the music and just the joy of the activity. And incidentally, it was also checking off from my daily, physical activity.
Yeah.
So can you find things that you enjoy, that can also give you that boost? And I think one of the biggest barriers is this perception, which is totally makes sense if you don't know the research, that if I'm fatigued, I feel tired and lack of energy. Why are you telling me to expend more energy? And if you think about like the people's perception of like the spoon theory, which is that you only have a certain number of spoons you get started with at the beginning of the day, and every activity you do uses a spoon, you're like, well, why am I going to use some of my spoons on exercise? Now, I know I know we both know that the evidence is actually opposite, that exercise or a physical activity leads to improved fatigue. How do you get people to understand this until they try it? Because I did not. I was I was just mind blown when I learned that. I was like, why does this make sense? Does not make sense.
Yeah, it's counterintuitive, right? It's like, well, if I'm tired and I exercise, am I going to be more tired?
Yeah. Yeah.
And what I tell patients usually is the answer is yes at first. Give me 2 weeks is what I tell them. Give me 2 weeks to let your body adjust, because there are a lot of things physiologically that happen with pain when you start to move, and with depression when you start to move. Pain and depression are also affected very positively by movement and by physical activity. And I think, this is my own theory, I think that all feeds into the fatigue. And that's where a lot of my research is right now, is on fatigue. And I think once you start moving, I think some of these other things come into effect. You start to feel less pain after about 2 weeks. Like I said, like all of us, we start a new activity, it makes you sore, right?
Yeah. Yeah.
But you have to keep going and let your body adjust. And so your pain goes down, your mood improves, your fatigue improves, your sleep improves. And then eventually your strength your range of motion, your all of those other things that we think of as the traditional benefits of exercise kick in.
Yeah.
But you got to give it that 2 weeks, and you'll feel better eventually. It, like I said, at first, no, you're going to feel
Yeah.
tired because you're not used to it. Your body has not made those proper adjustments.
Yeah, it reminds me a little bit of like, and I know that this is not to go into massage as a modality for RA specifically, but when I had gotten a couple massages in my life prior to my car accident in 2016, I kind of feel my joints definitely hurt more after a massage. I was like, this is weird. Like, this is not helpful for me. So then when I started getting them consistently for my neck after my car accident, I realized that this is my layman theory, like slightly informed of being an OT, that I think what happened is that initially, yeah, the first couple massages, I almost felt like it's like, well, a lot of your immune system is in your lymph, right? Or circulating through your lymph. So you're loosening up all this lymph that's all been like kind of congealed together, right? Around and in your whole body. And it's kind of initially my joints, all of them hurt worse after a couple massages. But then when I started getting them more regularly, that effect went away, where it was no longer kind of inflaming my joints. And so I think potentially exercise is moving your lymph too, right? It's getting all your circulation, everything's pumping. And I just think it's like, if you want to exercise, the benefits of physical activity for rheumatoid arthritis are so far beyond the actual joints, it's almost ironic, because you're like, what other intervention do we have, a natural intervention other than sleep, that can help fatigue? It's movement, Yeah. And they actually, I can give y'all some of in the show notes, some of these citations, but for my self-management program, I put together this list of like, here's what exercise, and I just use the word exercise, is associated with for rheumatoid arthritis: less pain and stiffness, less fatigue, better sleep, improved strength, not surprisingly, but improved mood, improved cognition. What other tools do we have for brain fog that actually work? Again, everything's interrelated. So you got to sleep too, but exercise, movement helps your sleep. Decreased risk of cardiovascular complications, extremely important for us because of the comorbidities, and then decreased risk of osteoporosis, because you're load bearing on your bones. So you're like, oh my gosh, this is not just about building muscle to support my joints mechanically, although that's helpful. It's about these systemic symptom improvements. So,
oh yes, I got my first DEXA scan of my life.
Yeah.
I'm 56 years old. I got my first DEXA scan ever, and I'm proud to say it was fine.
I got mine like 5 years ago or something. And I was like, oh my God, thank God I was a runner for so many years too. I was wondering if that was why.
Yeah, I'm a black belt, and that's where
Oh, wow. Well, and okay. So that's amazing. Yeah. And I'm glad that we talked about fatigue and exercise, because again, I think that would be logically would make sense for you to be like, I'm tired. Why are you telling me to move? But hopefully this little conversation has helped you understand that the evidence, and they'll take randomized control trial evidence. Half the people are not moving, the other half are in an exercise intervention, and they consistently, through multiple studies, are showing improved fatigue levels, which is really exciting, because your medications don't always work as strongly for fatigue as they do for pain, right? They're like different whack-a-moles, which is so fascinating how sometimes I joke that they're on the same whack-a-mole, like that old, arcade game, versus they're on different whack-a-moles sometimes. But one of the things that I found helpful, tell me what you think about this, but when we talk about getting started for exercise, also thinking about or movement, physical activity, thinking about 3 main types has helped me, like the pillars being cardiovascular, getting my blood pumping to a moderate level, and weight or resistance training, or getting my muscles challenged, and then stretching, like as 3 kind of separate buckets.
Yes.
Do you also, I know that seems overwhelming to some people, probably because it's like, that's 3 things, so I just want to do one thing. But certain things like
it's fine to start with one.
Yeah.
It's fine to start with one. But those 3 things are important, because they're important depending on what stage of your disease you're in, whether you're in an active flare versus inactive disease, or coming out of a flare. Those 3 things, you're going to use those in different ways, which again, PTOT can show you how to do this.
Yeah.
during a flare, resistive exercise isn't appropriate. It's too painful. It's too damaging to the joint.
Yeah.
Range of motion, light stretches, perfect.
Yeah.
Coming out of a flare, you can add that cardiovascular stuff that's not real heavy into a joint strain, but it gets the heart pumping, like you're
Yeah.
swimming, you're biking, you're walking, you're things like that. And then once your disease is inactive, that resistive exercise is a great thing to add at that time, because now your joints can handle it better. And so the type of exercise is really important, as well as the amount.
Yeah, and I'm going to draw from my own completely anecdotal evidence, because I haven't seen any studies on people with RA that isolate resistance training and muscle building from the cardio and the stretching. But I have in my own, they call it self-evidence, right? You have developed your own symptom tracking is developing self-evidence, evidence from your own life. And so last September 2023, I started doing 2 personal training sessions a week. And I told myself, I'm going to start with personal training at my husband's job because it's a spouse benefit. But I was like, if these people don't know what they're doing, I'm going to PT, because I was kind of skeptical, because again, the quality control can vary, but I was very fortunate one of them's a pre-PT student. She got into PT, getting her doctorate in PT, but she's taken a year off to earn some money before. So anyway, she's incredible. And I have been blown away. So I have gained my goal was to gain weight gain muscle, and because I was starting to feel weaker, I could just feel it, just being in my 40s now, and I've always been into cardio. I've always liked that kind of endorphin high, the runner's high, all that stuff. I've done running the last 10 years or so, but I've been doing the exercise bike, but I hadn't been doing, I was saying my upper body just feels so weak, my arms and my back, and my posture is getting bad. So I'm like, okay, I'm going to do weight training. The benefits, I was hoping that I would get better posture and, feel in my body more strong. Those were my main, and I knew all these other benefits are probably potentially going to happen. The 2 huge things that surprised me that have been so noticeable have been improved energy, decreased fatigue, and mood. And I think sleep has to do with it all too. But I don't know I'm just sharing this for anyone listening in case you're because sometimes people are I don't like the cardio because I don't like getting sweaty as much, although you do sweat when you weight train. But I've been really blown away by how much, better I feel now that I've been in this muscle training and, life now. And, I'm not aware of, again, any research that totally isolates the resistance training, but it's been a really positive thing for me. If you have access to personal training or PT to help you build muscle, that's my little words of encouragement, I guess.
Yeah. And for adults, the American College of Sports Medicine recommendations for physical activity are, the 30 minutes a day, 5 days a week of cardio, but also 2 days a week of resistance training. And that's for all adults. And there isn't any reason why somebody with RA can't do that in a modified way.
I'm doing the 2 days a week. I got it. Yes.
Yeah, you got it. You're there. And so those general guidelines for adults, they count for people with rheumatic disease as well. It's just you probably have to start much smaller and maybe work your way up. But anything, if it's not 30 minutes, then that 30 minutes can be broken up into 5-minute intervals. It doesn't have to be 30 minutes all at once. If you're doing 3 10-minute sessions of whatever, walking, swimming, biking, whatever exercise you like, gardening, something that makes you a little bit breathless, you're doing something for your heart. And if you're lifting something that makes your muscles tired, you're doing resistance activity. Even if it's not a formal thing, you're taking the trash out. That's resistance exercise. You're working in the yard. That can be both cardiac and resistance. And again, a PT, OT can help you figure that out, can help you kind of break it down and see what you're already doing that you don't realize that you're doing.
100%. Yeah. And when we say PT or OT, we're saying physical therapist or occupational therapist. I'm always trying to listen for what my some people are listening what do they mean?
The lingo,
Yeah, the lingo. And I think for me, it's helpful to separate the three, the cardio from the muscle resistance training to the stretching. Not that certain activities can't hit all three. Like yoga is a good example, one that definitely hits the stretching and resistance training sometimes, depending on what the positions are. Or a lot of cardiovascular stuff is also helping build muscle. But you know, a lot of times people don't understand, going back to something we talked about at the very beginning, the minutia, or the amount of little tiny tendons and muscles in the human hand, and how helpful it can be to do like a stretching routine. And that a physical therapist or occupational therapist can give you a set of you know, home program or recommendation, so you don't have to be looking at this, figuring it all out on your own, you know.
Right. And they can break it down and they can say, here, this is what you can do if you're having a flare. Here's what you can do if you're coming out of a flare. Here's what you can do if your disease is pretty stable. You know, there should be, it should be 3 parts.
Yeah. I that's so key, because I think that's, it's not a static set of recommendations that you're like manically doing every single day. Like, okay, well, this is my plan. I have to do 30 minutes of moderate intensity cardio today. So I'm just going to do it, even though I'm in a horrible flare. No, we have to build in that flexibility. So I think that's so helpful that you do that with your patients. I just want to make sure, so I feel like I keep going on my own tangents, but what are some of the things, that in the clinic that you run up there in Maine, you're still okay to go a little over? Is that, or is that okay?
That's fine.
Sorry, I didn't mean to be, that was a leading question. But you know, what have been some of the things that people have like, you know, I gave my little anecdote of my experience, my positive experience with increasing specifically my resistance training, muscle building. What are do you have any other like kind of success stories, or any, I'm sure you can probably pull a lot of anecdotes. Like, what are some of the things that people tend to say that surprise them about improving their physical activity, or things that they've enjoyed?
My favorite one was a woman. I was doing a patient education summit. That was part of my research, was doing some patient education groups. And one woman, we were talking about fatigue and we were talking about brain fog. And she's like, I thought I was getting dementia.
Oh, I've heard that in my groups too.
And I said, no, brain fog is a thing. That is a thing. You know, I mean, if you could see my office, I've got like Post-its everywhere, you know, just to help me remember things. Yeah, I've got them all over the place. And she was just amazed that that was real. And it wasn't her losing her mind. It was a result of her arthritis and, you know, her pain. And, you know, we do a lot of pain science education about, you know, when people start to kind of fall into that chronic pain behavior and that chronic pain, you know, it's like a sinkhole. Once you get in there, it's hard to get out. And talking about, you know, chronic pain is real pain. But your body is reacting to it in a way that is not productive for you. And once you can recognize that, and we do a lot of education about the pain science that's kind of coming out, it's a kind of a hot topic in PT right now. Pain neuroscience. And you know, it's like anything, some people respond really, really well as soon as they realize what's happening in their brain in response to this pain, which again is real. And perception is individual, but pain is real. And knowing how to manage that pain in their head before they manage it outside their body.
Yes, I think one of the, I don't know if I'm reading between the lines correctly, but one of the things when you said, you know, chronic pain behaviors, or a common one, is guarding or resisting movement, not wanting to move. And it's again, it's intuitive. It's logical to say, in the same way that with fatigue, I'm tired, it does not make sense to spend more energy. We're told, listen to your body. Well, my body, pain is the body saying, don't do anything. Like, don't move this thing. It hurts. Like, I'm telling you to stop. But with chronic pain, you have to learn that body, that signal is actually giving you information that's not 100. It's a too big response to a small stimulus. It's like you have a pot of water that's getting a tiny bit warmer, and for some reason the thermometer is like, oh my God, it's boiling. Wait, stop. You know, you're like, oh, Yeah, so I don't know, that's probably not the best analogy, but yeah, that we have to learn everything is so much more complicated than it seems at first, right? It's you have to listen to your body to understand your own body's rhythms and if you're in like a massive flare, but if you're not in an overall systemic flare, your body's you're having some stiffness in a certain joint, movement is actually going to relieve that stiffness more so than resting, right?
Yes. Yeah. Yeah. And it's called centralization of pain is the
Yes.
technical term for it. And when the pain centralizes, it does. Your body reacts like it's a 4 alarm fire.
Mhm.
When there isn't actually damage being done, because pain means damage, right? And so usually that's the cycle. But what happens with chronic pain is the pain now is reacting so high that it's like there is damage, but there really isn't. And so recognizing when there's damage and when there's not is a really big milestone for
Yeah.
someone with chronic pain, being able to make that distinguish, to distinguish between the two. It's amazing the difference once and a PT can help you
Yeah.
through that process, that cognitive process, help figure that out.
And especially if their PT is more trained in
Yes.
if they're up to date with current science, pain neuroscience. 'Cause like you said, it's really changed a lot. They used to say, I mean, they used to put, I've had interviewed people for this podcast who are in serial casts as
Hmm.
JIA patients. I mean, like, which is the absolute worst thing we know now to do would be to immobilize the
Right,
joint in
right.
a typical situation. And so I'm going to refer you guys listening back to episode 93, also with pain research Dr. Afton Hassett. You probably know her.
Hmm.
I don't know if you know her from University of Michigan,
Yes.
but she's done a lot of great education as well on pain science, and she has a great book that's kind of disentangling understanding chronic pain. So the chronic pain reset, which I think is great. So
Yes.
um, and going back to the kind of the concept in general of like understanding that we have these pillars of physical activity, the cardio, muscle resistance training,
Hmm.
stretching, and then we also have overall lifestyle pillars or lifestyle interventions, integrative
Hmm.
treatments for RA. Like we talked about, exercise is one, and then diet, nutrition, sleep and rest, mind, and then the other one we haven't talked much about is mind, body, and mental health. Managing our
Hmm.
stress,
Yes.
managing our mental health, and I'm going to refer people listening also to one other thing that I created with a couple other um, of my rheumatoid arthritis friends, which is called like, I made these charts. So I said, and it's called lifestyle pillars for rheumatoid arthritis. Each person's balance is different. And the charts are the 4 things: sleep and rest, exercise, nutrition, and stress management, which is kind of catch all for mental health. And if you're putting that in a pie chart, how much of the pie is taken up by each one of those? For some people, like Dr. Singla, half of it is sleep and rest, and then nutrition is the second biggest one. For Renee, nutrition is half of it, and then the other 3 are equally divided. For me, it used to be exercise wasn't as big because I wasn't utilizing it as much. Now
Hmm.
I'm realizing what a bang for the buck I'm getting. So I'm doing a lot of exercise, physical activity, and then sleep and rest. And nutrition's a small part. I've never had as a nutrition intervention make a noticeable difference on my rheumatoid arthritis, but because of understanding overall the benefits of like an anti-inflammatory, Mediterranean style diet, I do still follow that.
Hmm.
It's just good for your health overall, but
Yeah.
so understanding, I think it's important for each person to get to the understanding that, okay, it's not a one size fit all. Would you agree
Yeah.
with that?
Yeah. And I actually think of it as a circle, and
Yeah.
all of those things: sleep, exercise, fatigue, pharmaceutical, because there is a pharmaceutical component, all of those things and lifestyle things that we do, as well as our medications and things, are in a circle. And anything in that circle that you can tackle helps everything else in the circle. So it helps it to be less overwhelming, because if I decide, okay, I'm gonna work on, say, exercise. Exercise is going to help my sleep. It's going to help my fatigue. It's going to help all the other things. And it's going to help my medications work better. It's going to help me feel better. My depression is better. It helps everything else. Or let's say I'd want to work on my depression, and I'm going to go see somebody and talk to somebody, a therapist, a counselor. And then that improves, my mood improves, that helps me better able to exercise. And, it's
Yes.
all, you can pick one thing to start and
Yeah.
it's going to improve everything else. And then you can add as you feel ready.
100, yeah, 100%. And I'm really glad you mentioned medication because I do talk a lot on the podcast about the importance of understanding that the evidence for, um, rheumatoid arthritis medications is, if you compare that to lifestyle interventions, I think the latest research I saw was like around 95%, or maybe give or take what 10%, let's say
Mhm.
at the very least amount would be maybe 85% of people with rheumatoid arthritis are going to need to take medication
Mhm.
to control the disease. And my attitude about that has been, to consciously choose to feel really grateful about that and to kind of see that as a positive thing. I'm so great. There's a lot of people, friends I have with rare conditions that don't have any medications, they don't have
Mhm.
any evidence-based thing to do. They're just flying blind. So if it's not an either or, most people who are doing lifestyle interventions are
Yeah.
doing them in conjunction. It's not like you have to choose one or the other, but
Right.
we're not, I don't want to create like a false equivalency or whatever to say like these are just as strong as medicine. For a lot of patients, medicine is going to be, the pharmaceuticals will probably be the foundation of your intervention pyramid. But
Mhm.
these are things that at least you can control in your daily life a lot more than your medication.
Right, and all those little things that you implement, as you implement them over the course of my lifetime, I've implemented a lot of little things. I mean, you look at my kitchen
Yeah.
and it's
Yeah.
set up. I like to cook and it's set up for someone with arthritis. I have, the rocker knives and I have all of those things and I have it set up efficiently because that's what I love to do. And
Mhm.
I over the years, you implement all these small changes and it really helps your longevity of your joints and your
Yes.
mobility and your movement.
Yeah.
It's not like a one-shot thing. It's over the course of a lifetime. You can manage it and you can be successful and you can do the things that you want to do. You just have to modify it and you just have to kind of work up to it.
Yeah.
Don't say I'm not going to be able to do this, this, and this. Again, find the right professional to maybe help you figure out,
Mhm.
is there a way I can do it or do a part of it? This thing, whatever this thing is that I love to do. Because
Mhm.
that's part of the joy in life, and there isn't any reason why you shouldn't have joy, right? Just because you have RA, right?
Well, and I think, yeah, for me, part of, my overall endeavor here is trying to
Mhm.
figure out, how do we thrive with
Yeah.
these conditions? And for me, along those same lines, I would just add that part of thriving for me has become understanding and accepting that there may be things that I can't do the way I used to do. I'm probably not going to be a soccer player. I was a soccer player through college, and I played with my husband when we first met and stuff. But ever since, particularly because of a car accident, and I don't want to risk my neck through any headers or collisions.
Mhm.
It's not, I think it's important to give yourself space to grieve the loss of something that
Mhm.
might be important to you, or for someone else it might be. You can get to a point where you use all the tools in your toolbox. I go to physical
Mhm.
therapy, I'm going to personal training, I'm exercising, I'm sleeping, I'm talking to my doctors about my meds, and there's going to be a point where you might reach a ceiling where you're like, wow, this is as good as we can manage this, and I still have XYZ lingering
Mhm.
symptom. That's when, for me, the therapy and having coping tools to say, okay, I can make space for this grief and this
Mhm.
sadness about not being able to do certain things, but also make space for embracing all the things I can still do. And like you said, just looking at what's still possible and like with a joyful gratitude, you
Mhm.
know. But I don't know if that resonates to you at all. Like, do you have anything that you can't do? Because you seem like so functional. Like, what are you not doing? No, just kidding.
Well, you know what? I don't know. Maybe I'm just really stubborn, but
Good for you.
I play softball. You
Good.
know, I'm a second degree black belt. I work full time. I raised my children, and I've had to modify things along the way, and I know how to do that. As a
Yeah.
physical therapist, it kind of comes naturally to me, and
Right.
so I find that I live for my best days, not my worst.
Right.
you
Right.
know,
Yeah.
and so I very rarely say I can't.
Yeah. Well, and
And,
that's,
and if I can't, I tried it, it didn't work, it's okay.
yeah.
I'll find something else that I like to do.
Yeah. Yeah. And that is a like compensatory approach sometimes is super helpful. Like for example, I coached my son's soccer team when he was 8 years old, and it was a way for me to, channel my love of soccer in a way that
Yeah.
wasn't going to hurt. Again, I would be playing soccer still on like a, adult co-ed if it wasn't for my neck. I would.
Mhm.
It's too, I also had a concussion. It's just, I had multiple concussions as a kid. And then
Yeah.
the car accident kind of put the nail in the coffin. And now I am how I am today. No, I'm not saying nail in the coffin. It's saying that my executive functions are very precious to me. So I'm not going to put my head or my neck in any activity that I might get
But
injured.
and again, it's a choice that you made. It's not
Yeah.
life carrying you all along and you're just saying, oh, I can't
Yeah.
do that. You're like, no, this is the choice that I am making. And
Mhm.
that's
Mhm.
important to make that choice and not just say, I can't do that because I have RA. I can't do that because I
Mhm.
do this. Can't do that because I'm in pain. You're not really making a choice there.
Yes.
To be able to make that conscious choice, say, what, I'm going to coach soccer because I love soccer and I'm going to coach my son's team. That's fun.
Yeah.
I did the same thing with softball. I coached my kids' softball team and it was fun, a way to again find that joy in life and make a choice, not let the disease carry you wherever it may land you. I don't know
Well,
if it makes sense, but
that's beautiful. When I was just going to ask one of my last questions, as though it's like, what advice do you have for newly diagnosed patients? But I feel like, everything you said has been so, I think, helpful to a newly diagnosed patient. But just because I gave you these questions ahead of time, is there anything else you would want to say to like a newly
yeah,
diagnosed?
build your network. Build your network of health professionals, of support groups. Find your good resources online, your good reliable resources online, and become informed
Mm,
about your diagnosis, because then you can be an advocate for yourself.
yeah.
um,
Yeah.
and I think that's really important to understand what your needs are, and by having a support group and by having a group of professionals, PT, OTs, counselors, whoever
Yeah.
you
Yeah.
can afford and whoever you want to have in your life, that helps you become more informed and it helps you advocate for yourself.
I mean, you're 100% speaking my language in terms of having a support group. Yeah, and I think I talked about this with some rheumatologists. I'm like, the fact that you're not proactively referring people to OT, PT, social works, like it's a tacit communication to these patients that they should be able to just figure it out on your own. Otherwise, why wouldn't they have told me to go to these places? You know what I'm saying?
Yeah. I asked my own rheumatologist. I said, "Do you refer people to PT?" Right? And he
Yeah,
goes, "Well, no." I said, "Well, why not? As soon as they're diagnosed, why don't you refer them to PT?" And he says, "Well, it's usually not covered."
that
I
is the
said, "But
trap.
it's not going to get covered unless the referrals are made. You got to keep referring, and
Yeah,
then maybe the reimbursement will come." But
right. Well,
I said it at the conference. We use that as an excuse, and I think there isn't any reason why you can't
yes.
get the referral. And if
And
the referral doesn't happen, at least it's important, and you've signaled that it's important by making that referral to the patient and to the insurance company.
And I've had this conversation, like I've gone to Washington, D.C. with
Mhm.
through the help, and I know you have done advocacy too. All the major nonprofits do a lot of advocacy at the state and national level, as well as, American College of Rheumatology, Arthritis Foundation, all these places. And I remember asking in DC with the American College of Rheumatology in 2019, like, I don't get why don't the insurance companies want to save money? A $150 or $200 1 hour physical therapy appointment is a lot cheaper than 1 month of my medication, which costs, $5,000 or whatever. And they're like, the lobbyist was saying that basically they don't care about, and this is just, sorry, side note, but potentially helping people understand. Sometimes the preventative care is not covered, like preventative care with a PT or OT to teach you about how to protect your joints, even if you're not in a horrible state yet, where you just got
Right.
diagnosed.
Yeah.
It's not covered because this is what the lobbyists said. All they care about is their quarterly bottom line, making money that quarter, not saving money for their insurance business long-term, because people's insurance is tied to employment. And so they might change jobs. Just thought, oh my gosh, that is just so short-sighted. You'd think they're figuring out with diabetes, because diabetes is so expensive and potentially deadly if not managed correctly, that they're giving people access to certified diabetes educators. Well, what about certified arthritis educators?
Yeah,
that's what we're trying to.
Arthritis, 1 in 4 people in the US, right?
Yeah.
I mean, that's
starting it today.
Population. Yeah. That's another whole podcast.
That is a whole, yeah. Thank you so much for, I asked you before and we can go over, and maybe I should have said, how much over can we go?
Oh, yeah, like I said, I have no constraints.
Yeah, so. I'm good. Well, I really want to come visit you in Maine. I have this idea of doing an arthritis world tour where I just go around the world talking to interesting people who have arthritis and help people with arthritis. So I think that would be so, yeah, sometimes I can see on the podcast, like where people are listening from. Actually, how do I get to my little calendar? Thing here, audience. Yeah, I can see that there's people in this little map, in Melbourne, Australia, in Perth, in Auckland, in Quezon City. Is that in Indonesia? Singapore, Frankfurt, all of Hawaii. 2 downloads in Honolulu in the last month. So I'm like, oh, I gotta go. Oh my God, I can't even pronounce some of these names of the cities. Copenhagen. Yeah. Oh my gosh, crazy. Okay, sorry. I'm getting distracted by this. Oh, Russia, Ulaanbaatar. Hello to whoever's in Ulaanbaatar.
Oh, well, if you ever need a valet, I'll come with you.
Oh, that'd be so fun. Well, thank you. This is super, super helpful. I really hope that I know that people listening will feel like they have a better handle on what the, physical activity can do for them, and how these integrative health guidelines can help them get like a good starting point. And hopefully they'll choose PT. I know that was one of the campaigns.
Yes, choose PT. Choose PT first. And the APTA's slogan right now.
Yeah. Then there's a lot of other conditions that, we didn't even talk about back pain or like ankylosing spondylitis and stuff, but there's so much great evidence about, physical therapy as an intervention for, back pain that can maybe potentially spare people having to get surgery and stuff like that. So, but if people are interested in following up with you, where can they find you online?
They can find me on LinkedIn, Kimberly Steinbarger. It's just under my name.
Yeah.
At K Steinbarger is my Twitter. Or you can look up Hudson University and just put my name in and you can find me there.
I love it. Well, that's so, and again, thank you for your service of running your clinic. I meant to say, because I've never heard of any other clinic that's specifically a pro bono clinic for people with inflammatory arthritis. So that's pretty amazing.
Yes. We see all kinds of patients, but that's my specialty is.
Oh, I see. Okay. Sorry.
I get referrals particularly for that because they know that I'm there.
Yeah. Yeah. Well, and maybe so much of it, unfortunately, there isn't like a great directory that I'm aware of like physical therapists or occupational therapists that can help you, that are like particularly great at arthritis, but it's really a word of
directory, the ACR directory.
Do they? Okay.
Somebody had asked me about it at the conference, and I wasn't there for some reason, but now I am.
Oh, so good. Okay, well, maybe
health professionals can go into that ACR directory for people,
so they can help people.
Yeah, if you're looking,
that's actually really good to know, because I think a lot of people ask me, how do I find you? I'm in Wichita, Kansas. How do I find a good? And I'm like, ask your rheumatologist who they hear good things about from their patients. Like, there's no great place.
What do they call it? Find a practitioner. It's on the ACR website. There's a find.
Okay.
Yeah, you can find. I know I'm on there.
Okay, I will put that on as well then.
Okay,
I'll put that on the show notes. The show notes are always found on like the Arthritis Life website, which the long URL is, we talked about earlier about long names, arthritis.theenthusiasticlife.com. But I usually just say, if you put in myarthritislife.net, it'll redirect you to my website. So, but I have paid for people listening who maybe are newer. For every episode, there's like a show notes page that has the full transcript of the episode, the video and the audio, and like links to things that we talked about today, like links to the 2022 ACR guidelines, which are also on rheumatology.org. But thank you so much again.
Thank you for having me. It was fun.
It was so fun. Okay, we'll talk to you more later. Bye for now.
You take care. Happy New Year.
You too. Bye.